Hi, class. Lecture time. So we're talking about our rhythms that originate in the ventricles. Remember we said these were our killer rhythms because patients that end up in these type of cardiac rhythms um, have a hard time recovering, and many of them code, um, and oftentimes despite great efforts, the patients still don't survive. So we're going to talk about the adverse effects of each of the rhythms. With your accelerated idioventricular rhythm, there's usually no ill effects as long as that heart rate stays up, because your heart rate is close to normal with the accelerated idioventricular rhythm. You have a rate of between 40 and 100. With the idioventricular rhythm, however, it's not so good. These patients have decreased cardiac output, cardiovascular collapse, and it may or may not result in a pulse. As we can see here in our illustration, it says this patient is going down if he stays in this rhythm too long. Here's our dressage the point. This rhythm may be tolerated for a short period, but it usually leads to cardiac arrest. And then next we have our PVCs, which can cause cardiomyopathy. They are an abnormal heartbeat that begins in the heart's lower chambers. The greater the number of PVCs, the greater the likelihood of long-term effects on the heart. So we see the adverse effects. If you just have, the patient just has occasional PVCs, the doctor may not be so concerned with it. However, when they start to have 6 or more per minute, they can get into what's called an R on T condition, and then quickly progress into a lethal rhythm. Then we have VTAC. Patients can only tolerate VTAC for a short period of time. Any length of time in VTAC, that patient's going to go into profound shock, become unconscious, and if not treated, they will die. And oftentimes, even after treatment, some of these patients still don't survive. VFib is another lethal rhythm. Again, patients cannot tolerate this rhythm. They get into profound cardiovascular collapse. There's no cardiac output, there's no pulse, and there's no breathing. You see the heart is just sitting there and it's just quivering. And then you have your agonal rhythm, which is our dying heart. This patient gets into profound shock. There's usually no pulse. They're usually unconscious, and they quickly progress to death if left untreated. And then, of course, our asystole. Again, all of the heart's pacemakers have failed by the time the patient gets into an asystole rhythm. And then, of course, this patient will not survive if not quickly treated with attempts to save their life. So that's all we have today. Your assignment is going to be to complete the chapter checkup on page 141. and I will see you guys next lecture.